Good afternoon and welcome to the first in a series of 3 webinars presented by Vermont Information Technology Leaders. This series will cover important topics related to CMS Meaningful Use Incentive Program in 2014 for eligible professionals. Today we will focus on Meaningful Use Stage 2 requirements and schedule. My name is Rob Gibson. I'm the VP of Marketing and Business Development at VITL. I'm joined today by members of our eHealth Services team. Our eHealth Services team is a team of health IT consultants that bring clinical and practical management expertise to you and your practice as you strive to achieve meaningful use. Jennifer Morgan will be our presenter today, and Suzanne McEachran and Ann Gilmet will be panelists. Now let's cover a few logistics for our call today. You can interact with us through the instant message feature in your GoToMeeting window. Please send questions as the presentation proceeds. If possible, our panelists will answer your questions real time. Other questions will be queued up for discussion during the Q&A period at the end of the presentation. We will also be monitoring our Twitter feed using the hashtag VitalMU. So now let me turn the mic over to Jennifer.
Thank you for joining us, and thank you for that introduction, Rob. Looking forward to reviewing Meaningful Use Stage 2 with you and giving you a more in-depth look at what you will expect for Stage 2 requirements. Our agenda for today, I'm going to give a quick overview of Meaningful Use Stage 2, what the structure looks like, and a few details, and then we'll dig into each core and menu objective, looking at what you need to do in order to meet the measure if there are any exclusions that may apply. Towards the end of the slides, you'll see a list of resources, links to the CMS website. When this presentation is posted to our website, you'll be able to view the slides and click through to the CMS tip sheets very easily. So those you will have for your convenience. And of course, we'll have a Q&A towards the end to help answer any questions that you may have. Okay. Stage 2 final rule was adopted in September 2012, which defines the Stage 2 rules and also outlines the changes that were made to Stage 1, which began in 2013 going forward for Stage 2 and Stage 1 rules. Some clarification on timing. In December 2013, CMS announced that there is a delay in the Stage 3 implementation. So Stage 3 will not start until 2017. And for those early adopter EPs, they will be doing Stage 2 for 3 consecutive years. That would be 2014, 15, and 16. This will probably sound very similar to those early adopters who started Meaningful Use back in 2011. They did Stage 2 for 3 years because Stage 2 was delayed by 1 year. So we're seeing a similar pattern with Stage 2 delay and a Stage 3 delay. There are also some changes to clinical quality measures, and also of note is the requirement for a 2014 certified EHR in order to do Stage 2 Meaningful Use. A couple of things to note for Stage 2 as we move through this presentation. It is mandatory to have the 2014 certification for your entire reporting period. So you must wait to start your 90 days of attestation for Stage 2 once that certification is up and running. There cannot be an overlap from your 2011 certification to your 2014 certification. Another important note is that the menu set exclusion is limited. There's no longer can you take an exclusion for menu objective when you could meet another objective without an exclusion. So we'll go over the menu objectives as we go through these slides. And another change is the clinical quality measures for EPs are needing to report 9 of 64. So that's an increase from what you are familiar with from Stage 1. And a little summary of Stage 2. So the structure remains the same. You'll be familiar with core and menu. That's going to be familiar to you. Most of the Stage 1 menu objectives that you are familiar with become core measures for Stage 2. Many of the Stage 1 measures were some of them were eliminated, and some were combined with others. So you'll see that as we go through these slides. Most minimum percentage thresholds were increased. So if it was a 50% threshold you had to meet for stage 1, we may be looking at 80%. There's some new objectives we'll review, and again, the list of quality measures, clinical quality measures, increased from 38 to 64, so there's many more to choose from for stage 2. Patient portal functionality replaces electronic copy and electronic access. We'll see where those come into play as we go through. So let's jump in. Core objectives. For EPs, you must meet 17 of 17. These are your required measures. There's no leniency. These are the ones you have to attest to. Okay? Number 1, let's dig in. Number 1 is CPOE, or use of computerized physician order entry. So the requirement is that you have to report greater than 60% medication, greater than 30% laboratory, greater than 30% radiology orders created by the EP during the EHR reporting period recorded using CPOE. So how do you meet this measure? The EP or the appropriate staff person has to use the CPOE functionality in your EHR to track and record orders for medication, laboratory, and radiology. There are exclusions. The exclusion would be if the EP writes fewer than 100 medication, radiology, or laboratory orders during the reporting period. So that would be the only exclusion for the EP. Okay. Number 2, core measure, e-prescribe. So this requirement changed a little bit. It looks familiar to you from stage 1, but the requirement now is greater than 50% permissible prescriptions written by the EP are now compared to at least one drug formulary check and transmitted electronically through your EHR technology. So how do you meet this measure? Prescriptions are written and compared to one drug formulary check and sent electronically through the certified EHR technology. So this is one of the measures for stage 2 that's combined. We're talking about not only e-prescribing, but that there's the formulary checking that's happening as part of this measure. Are there exclusions? Yes. If an EP writes fewer than 100 prescriptions during the EHR reporting period, or if there's no pharmacy within a 10-mile radius of the practice that's e-prescribing. We have found in Vermont that will probably not be applicable to any organization, that there are pharmacies that accept e-prescribe throughout the state. So that exclusion may not apply, but the fewer than 100 prescriptions very well could for your physician or for yourself. Number 3, core measure, record demographics. The requirement is greater than 80% threshold of unique patients have demographics recorded as structured data. How do you meet this measure? It's identical to the way you met this measure last year for stage 1, pardon me. So we're still talking about preferred language, gender, race, ethnicity, date of birth. Exactly the same, no exclusion. So this is a must meet. The threshold is increased, but it looks identical to how you met this last year. So no big surprises or changes with this measure. Number 4, we're talking about vital signs. The requirement is an 80% threshold, greater than 80% unique patients seen by the EP have blood pressure for patients 3 and over and height and weight for all ages patients as structured data. How do you meet this measure? Record blood pressure in your certified EHR technology for all patients 3 and over, and record height and weight in your certified EHR for any patient. Of note here, what you're seeing for a difference is that we're talking about an 80% threshold, and we're talking about an age range for patients that's now 3 and over. So your pediatric practices out there, this is an age difference that will affect you. We're not talking about 2 and over anymore. Are there any exclusions? Yes. EPs can take an exclusion from recording all 3 vital signs if they believe it is not relevant to their scope of practice. Or an EP could exclude just blood pressure or just height and weight. The emphasis here is that the EP has to determine whether or not this is relevant to their scope of practice. They cannot exclude it. Your primary care provider is going to have a hard time saying it's not relevant to their scope of practice, for example. The second exclusion is the EP could exclude recording blood pressure if they see no patients age 3 and older. All right. Number 5, record smoking status for patients 13 years and older. This one looks familiar to you from stage 1. The threshold has increased to 80%. We're still talking about patients age 13 and over. We are still going to be recording it the same way as structured data. You need to have the smoking status in the patient's record. The exclusion is also the same, only can exclude if the EP sees no patients ages 13 and over. Number 6 is clinical decision support. This one is a change from stage 1, so let's talk about this in a little bit more detail. For clinical decision support, you must implement 5 CDS interventions related to 4 or more CQMs, if applicable, at the relevant point in patient care for the entire reporting period. The second part of this measure is that drug and drug allergy checking are on for the entire reporting period as well. So this is a combined measure. We're talking about clinical decision support and drug and drug allergy checking. How do you achieve this measure? How do you meet this measure? Both of the following must happen. 1, you must implement 5 CDS rules in your certified EHR, and they should be related to 4 or more CQMs, if possible. And then the second part of how this must be met, the drug and drug allergy checking functionality must be enabled in your EHR for the entire reporting period. Are there exclusions? Yes. However, the first part of this measure, for doing 5 CDS interventions, there is no exclusion. That must be met. There is an exclusion for the second part of this measure for the drug and drug allergy checking. If the EP writes less than 100 medication orders during the reporting period, that part of this measure could be excluded. Okay? Number 7, provide patients with the ability to view online, download, and transmit their health information. So let's talk about the requirements of this measure a little bit. There's 2 parts to this measure. The first part is that greater than 50% of all unique patients are provided online access to their health information within 4 days of it being available to the provider. The second part of that is that greater than 5% of the patients view, download, or transmit to a third party their health information. How do we meet this measure? Provide online access and assure that greater than 5% of your patients actually access the online health information. Are there exclusions? Yes, there are. So the first exclusion is that an EP neither orders or creates any information listed or for inclusion as part of both of these measures, except for patient name, provider name, or the office contact information. The second exclusion would be that the EP conducts 50% or more encounters in a county that does not have 50% or more of its housing units with broadband availability. So just of a side note, exclusion number 2 is not applicable for our state. Broadband availability is greater than 50% in all counties. So that one would not be an exclusion, although number 1 may be applicable to your EP. Okay. Number 8, clinical summaries. This one looks very familiar to all of you, I am sure, from stage 1. The only change we're looking at for clinical summaries is that instead of having 3 business days to get your patient a clinical summary, you now only have 1 business day. The threshold has stayed exactly the same, greater than 50%. You need to provide it within 1 business day. The only exclusion is that there were no office visits. So we may see with the implementation of stage 2 requirements and people using patient portals more that the clinical summaries may be pushed electronically. So keep in mind that some of these measures that we go through today, you may be able to achieve them through use of your patient portal, but the clinical summaries has only changed by the amount of time in which you need to get your patient that summary. Okay. Core measure number 9, protect electronic information. Health information. This measure should also look familiar to you. The requirement is that you conduct a review, a security risk assessment in accordance with the HIPAA Rule 45 CFR ... including addressing, so here's the difference in wording for this year, including addressing encryption and security of data at rest. Okay, that's the change for this year for this measure. and implement security updates as necessary and correct identified security deficiency as part of your risk management process. How do you meet this requirement? Many of you know just how to meet this requirement because you've had some assistance from VITL as we've gone through doing some of these security risk assessments. You need to comply with the HIPAA requirements to protect patient information, and you do this by conducting an SRA of all of your systems. There is no exclusion. This is a must meet with no exclusion. Number 10. Lab test results into your certified EHR as structured data. So this looks familiar to all of you as what was a possible menu objective. Now we are talking that is core and required. So how do we meet this measure? Greater than 50% of all of your clinical labs ordered by the EP during the reporting period whose results are either positive, negative, or of a numeric value are incorporated into your certified EHR as structured. So how do we meet that? Exactly how the measure requirement reads pretty much. Your lab orders and results that are positive, negative value or numeric are entered into the EHR as structured. Any other test results that are not positive, negative, or numeric won't count towards this measure. There is an exclusion if the EP does not order any lab tests during the reporting period that have positive, negative, numeric value. They could be excluded from this measure. We see most practices and physician organizations meeting this measure by way of a lab interface. However, this does not require a lab interface. We are just talking about structured data being entered into your EHR. Okay. Number 11, generate lists of patients by specific condition. This should look very familiar to you. There are not any changes to this measure. The requirement is that you generate a list of patients by specific condition. You can generate a list, whatever clinical relevance to your practice through your certified EHR product. There's no exclusion to this measure. Number 12, identify patients who should receive reminders for preventative and follow-up care. Okay. The requirement is that greater than 10% of all of your unique patients who have had 2 or more office visits with the provider within the 24-month period of time before the start of your EHR reporting period are sent a reminder for preventative or follow-up care per the patient preference. Okay. How do we meet this? The EP sends a patient reminder for preventative or follow-up care per the patient preference. So it's pretty standard. So you must use your certified EHR technology to send out your patient reminders. The exclusion would be that the EP has no office visits in the last 24 months before the beginning of the reporting period. Number 13, core measure, patient-specific education resources. Again, this looks familiar to you. It was a menu objective. Now we're talking core measure required for stage 2. The requirement is greater than 10% of unique patients with office visits are provided patient education resources. You meet this by using your certified EHR technology to recommend patient education resources for your patient by specific diagnosis, etc., things like that. There is an exclusion, pardon me. The exclusion would only be if the EP has no office visits during the reporting period. Okay, that looks familiar to you, I'm sure. Number 14, medication reconciliation. Again, we're talking about a menu objective that's now core, now required. And the requirement is that you perform medication reconciliation greater than 50% of all transitions of care when the patient is transitioned into your provider or your care, okay, back into your practice. How is the requirement met? The EP should reconcile medication lists by comparing patients' external medication lists obtained from the patient, hospital, other provider organization, and compare to the medication list maintained by you, your organization, your practice. Okay? It's a comparison. The exclusion would be the EP who has not received any patients for a transition of care into your EHR during the reporting period. And again, we're just talking about reporting period, 90-day period for stage 2 for 2014. Number 15, there'll be 2 slides for this measure. Number 15, we're talking about providing a summary of care record for transitions of cares or referral. This is a three-part measure, so let me read through what the requirements are, and then we'll talk about how to meet this. So the EP must meet all three parts of this measure. The first part of this measure is that a summary of care is provided greater than 50% of all transitions of care. Okay. Part 2 of the measure is that a summary of care is provided for greater than 10% of transition of care referrals for either, or is done either one of two ways: electronically transmitted through the certified EHR to a recipient, or where the recipient receives the summary of care record by an exchange facilitated by an organization that is an e-health exchange participant, or in a manner that is consistent with the governance mechanism the ONC has established for the e-health exchange. Okay? Part 3 of the measure is that the EP must also do one of the following two: conduct one or more successful electronic exchanges of the summary of care document to a recipient that has a different EHR technology than their own, or conduct one or more successful tests with the CMS designated test EHR during the reporting period. Okay, that was a lot. Let's talk about it a little bit more. How do we meet this measure? Okay, greater than 50% of patient referrals to another provider transferred out of your practice setting have either an electronic or a paper summary of care document generated out of your EHR. Of those 50%, 10% of them must be sent electronically, either directly to a recipient or using an e-health exchange. The third part is that at least one summary of care document is sent electronically, must be sent to someone else, another provider of care using a different EHR vendor, or to the CMS designated test EHR. Okay. There is an exclusion for this measure, and that is if the EP, you can be excluded from all three of these measures if there were no patient transfers. I'm sorry, I'm misspeaking. If there were less than 100 patient transfers. So all three parts of this measure could be excluded if the provider did less than 100 transfers. Okay? That's a little bit different of an exclusion than what we saw for patient transfer records last stage of meaningful use, so that's an important note. Number 16, immunization registry. Again, we're talking about one that moved from a menu as one that you could select to a core measure that is required for stage 2. The requirement is successful ongoing submission to the immunization registry by your certified EHR technology for the entire reporting period. And to meet this, it needs to be successfully submitting the information on an ongoing basis. There are 4 exclusions. The first one would be that the provider administers no immunizations. That exclusion may apply to you or your provider. Number 2 is that the EP operates in a jurisdiction where no immunization registry has the capacity to accept the standards required by the certified EHR technology for the reporting period. So that would be if our state registry in Vermont didn't have the capacity to receive the information from certified EHR, this is not applicable for our state. So that exclusion would not apply in our state. That's the same for exclusion number 3. This EP operates in a jurisdiction where no immunization registry provides timely information on capability to receive immunization data. That again is not applicable in our state. However, number 4, EP operates in a jurisdiction where no immunization registry has the capacity of accepting specific standards required by certified EHR at the start of their EHR reporting period, can enroll additional EPs. This one may be applicable for your organization or your EP if you're in the onboarding process of your immunization registry being implemented. Okay? All right. Let's move on to number 17. It's the last of our core measures, and then we'll jump into the menu set objectives. Number 17 is use secure electronic messaging to communicate with patients. The requirement is that a secure message would be sent through electronic messaging functionality of your EHR. by greater than 5% of unique patients or their authorized representative seen during the reporting period. So you use your EHR to send a secure message between patients and EP, and to meet this, greater than 5% patients must use this capacity to send a secure message. The only exclusions are if the EP has no office visits. The second exclusion is that the EP conducts 50% or more patient encounters in a county that does not have 50% or more of its housing and a broadband availability. We talked about that already. That's not the second exclusion is not applicable for our state. Okay, so let's talk about menu objectives. For stage 2, for EPs, must choose 3 of 6 menu objectives. And as we go through these, remember that if there is a menu objective that you can meet, you cannot select one to simply choose the exclusion that applies. Okay? Menu objective number 1 is submit electronic syndromic surveillance data to the public health agencies. The requirement is that the EP perform successful ongoing submission of electronic syndromic surveillance data to the certified EHR to the public health agency during the reporting period. Before we dig into this one too much, our state registry is not yet accepting syndromic surveillance for EPs, so this measure will not be applicable as a menu objective that you could choose for this stage. However, you will notice the exclusions that may or may not apply to your EPs. Again, these, as you may notice, when we looked at the immunization measure for core measures, the exclusions are exactly identical for this public health measure as it was for the other. So I'm not going to read through this 1 through 4 exclusions, but remember that number 2 and 3 are not applicable for our state anyway because of our registry. Okay, so let's move on. Number 2, record electronic notes in patient record. This requirement is that the EP has entered at least one electronic progress note created, edited, and signed by the provider greater than 30% of all unique patients with at least one office visit during the EHR reporting period. The electronic progress note has to be text searchable. So non-structured notes won't qualify, and the content needs to be character text. So drawings and other content can be included as long as it can be text searchable. You meet this measure by entering your EP must use progress note functionality in the EHR, and then they'll have the capacity to have those notes be text searchable. So this is a new menu objective, and there is no exclusion. So if this one is one you select, there's no exclusion. All right, number 3, imaging results accessible through certified EHR technology. The requirement is greater than 10% of tests whose result in one or more image ordered by the EP during the EHR reporting period are accessible through the certified EHR. So how do you meet this requirement? The test results which yield an image must be accessible through your EHR. So the image can either be stored directly in your EHR, or there's a link or some type of direct button you press within your EHR that brings you out to a way to view the actual image of the test result. We're not just talking about the results. We're talking about the actual image. Okay. The exclusions are this: that the EP who orders less than 100 tests whose results in an image during the reporting period, or the second exclusion would be any EP who has no access to electronic imaging results at the start of their reporting period. So those are the 2 possible exclusions for the imaging menu objective. Okay. Number 4, menu objective, record patient family history. The requirement would be that greater than 20% of unique patients seen by the EP during the reporting period have structured data entered for one or more first-degree relatives. So you meet this by recording first-degree relative health information greater than 20% of the time as structured data in your EHR. The only exclusion is that the EP has no office visits during the reporting period. Right. Number 5, report cancer cases to Public Health Central Cancer Registry. This format of the slide looks very familiar because we're talking about public health measures again. And we're talking about the requirement being successful ongoing, submission to a cancer registry. The exclusions are exactly identical to the other 2 public health measures. So, exclusion if the EP does not diagnose cancer directly, or in a jurisdiction where there's no public health agency that can accept or receive. So there are exclusions to this measure that may be applicable to your EP. The last menu set objective, report specific cases to a specialized registry, another registry measure for menu objective. And again, we're talking about the same, basically the same exact requirement, how to meet the requirement, and exclusions. So there may be an exclusion that applies to your physician, and this may be a measure that you could meet if you are sending data to a specialized registry. Okay. Now let's talk a little bit about clinical quality measures. For Stage 2, EPs will be required to report on 9 of 64 clinical quality measures. That's an increase of 3. The format or structure for Stage 2 for clinical quality measures is not you must report 3 core or 3 alternate core and then 3 additional. It's not worded that way anymore. It's just 9 of 64, a little bit more simplified. How do you select CQMs in 2014? So as I mentioned, must select 9 of a possible 64 and must cover 3 of 6 national quality strategy domains, and I've listed them here. Again, when you have access to these slides on the VITL website, there's a very helpful link at the bottom here where you can go and get a full list of the 2014 CQMs, and I would encourage you to do that. So recommended core CQMs, so CMS has published a recommended core set of CQMs for primary care providers and pediatrics, so 9 for each. They have just recommended what those 9 could be, and I've included a tip sheet at the end of these slides so you can go right to the CMS site and see what those 9 recommended are for pediatric and what the 9 recommended are for primary physician. Just something that CMS had recommended out of the 64 as a helpful helpful recommendation. Okay, so this slide here just has a few helpful links, some CMS tip sheets, comparison tables, things that you will find helpful as you go through preparing yourself for Meaningful Use Stage 2. So, do you need help with meaningful use? Contact VITL. We have a group of professionals who can help you through this. We have free funding through a statewide grant that has been that we are working on. Take advantage of our custom support plans, online assistance. Your friendly neighborhood e-health specialist can be contacted, and we'd be happy to help you. Also, we've listed our phone number and website here for you to contact us. And what I'd like to do is turn over and start seeing if we have any questions that we can answer live that have come through on the panel.
Okay, thank you, Jen, for that presentation. So we've had a few questions come in through the chat panel, through the instant message panel. I'm hopefully that folks can see those as we're answering them. If anyone else has a question they'd like to ask through the phone, there is a feature on the GoToMeeting to raise your hand. But if you're going to do that, you need to make sure that you're connected with an audio system that will allow you to speak to us. So you will either need to have your headset connected to your computer enabled, or you will also have to, or you'll have to be connected through a telephone line. So, so do we have any live questions? Do we have any new questions from folks? If not, what I might do is ask Suzanne to maybe recap some of the ones that have come in through the instant message panel.
Did we have anybody raising their hands to ask any questions that we would want to open their lines, or?
We do, but go ahead and answer a few written ones first while I get set up.
Okay. So some of the questions that I see that have come through, one is a great one, and it was a question about the menu objectives, if practices could exclude from the public health measures. And it is true that all of the public health measures, other than immunization, which is a core measure, can be excluded for stage 2. So that hopefully helps answer your questions. Yes, there's an exclusion because the state is not yet accepting syndromic surveillance, for example, for EPs, cancer registry, specialized registry. Those are exclusions that would be able to be selected or chosen for our state at this time. And I say at this time because those are all things that will be changing. You know, the state will eventually be accepting syndromic surveillance someday. So I just say at the time that we are looking at this today, the only public health registry or that we are able to send data to and that you cannot choose the exclusion for that for is the core measure for immunizations. So hopefully that's helpful.
Okay, thank you, Jen. We're going to open Bridget Kelly's line. I know, Bridget, that you've entered a question in the instant message, but it's rather complicated, so we've got Suzanne and Jen here ready to help answer that, but maybe we'll open your mic and let you ask the question.
Okay, well, hi, it's Bridget, and I actually have another question besides that one. But I guess I can start with that one. So when we're entering medications and orders in CPOE, I guess I'm a little confused. If the provider is the last one with the chart and he's told somebody to enter a prescription and he gets the chart at the end and he signs off on it, does that not mean that it's his entry?
It is his entry, and that would qualify for this measure. So whomever starts the order, as long as the physician is the one who signs off on it and completes that order or approves that order for the medication or whatnot for CPOE, that will satisfy this measure. What I would add is that it's important for you to understand how your EHR functionality works to measure CPOE and know where things need to be entered in order for CPOE to track appropriately. Does that help?
Yes, actually, you know, with the different vendors, at least with our vendor, we as users end up spending a lot of time arguing with them about what the rule is and how they need to make it get tracked, and you know, they try to make up their own rules.
Yes, we
that affect our workflow that are not really what CMS is asking for.
Well, I understand that. I've heard that too. We're happy to help you too if you reach out to your eHealth specialist and work through any vendor questions that don't seem to be matching up with what we understand the measure to be. We'd be happy to help you work on that.
Right. And so then my other question, if I can ask another question, is that okay?
Yes, of course.
All right. So my other question had to do with the imaging.
Okay.
And you know, as a pediatric practice, you know, I'm trying to understand what access means. So, you know, we're connected to the hospital through Meditech.
Mm-hmm.
So we, you know, not directly through our EHR, we don't get the images, but, you know, we can log into the hospital system on Meditech and look at an image
mm-hmm.
On a patient that we sent over, say we send somebody over for an x-ray.
Mm-hmm.
But we would never do that.
Right.
We would never, you know, my providers would not look at an image and have any idea what it says. We wait for the report to come back from the radiologist or whatever other, you know, specialist is providing the testing.
Mm-hmm.
And although we can look at the image, we never would.
Right.
Are we still required to?
So the imaging measure is menu objective. So you would choose that if it was one you wanted to for the 3 of 6. It also needs to, so remember there were 2 exclusions for the imaging measure, and if you don't have access to viewing the image, then an exclusion may be appropriate for that one. It sounds like you do have access to going outside of your EHR and looking at the image. That doesn't qualify for meeting this measure. It needs to be from within your certified EHR product. Either the image is there, or you have a direct link within your EHR that brings you directly to the image.
Oh, okay. So then that's not going to be an issue for us. Then.
Okay.
Sounds like.
Great. Thank you for that question.
Oh, okay. Thank you, Bridget. I think the next one we'll take out of the instant message. So there's a question from Roseanne. You mentioned certification at the beginning of the presentation. Can you explain further?
Yes, happy to. So for stage 1, you may recall that your EHR had to be certified in order to achieve meaningful use for stage 1. The certification for your stage 1 requirement was called a 2011 certification. That's when meaningful use started, was 2011. So for stage 2, because the requirements have changed so significantly and the stage 2 requirements are different, thresholds, etc., patient portal, things like that, a new certification needs to be present in your EHR in order to attest to meaningful use. In some cases, we're seeing that vendors have already upgraded to the 2014 certification or have scheduled for this new certification to be installed in the first quarter, second quarter of this calendar year. So the 2014 certified EHR must be in place for the 90-day reporting period that you use for stage 2 attestation for this year. So I would encourage you to connect with your vendor if you are not yet sure when your EHR certification will be implemented, or if it's already been upgraded and you're just not aware because it's something that may happen behind the scenes for you. So let's just take a look and see if there are any other questions that we can address for the whole group that may have come through electronically. Bear with me one moment. Suzanne, did you have one that you would like to?
All right, so we're looking at the one from Laurie Weissel then? Is that the one you're looking at, Suzanne?
Right. So Lori had questioned for CQMs that require LOINC codes, labs and radiology, does the LOINC code go on the order and result or just the result? And my advice to you would be you need to speak with your vendor and ask them how the report that's going to report on your meeting that measure will be read out of your system.
Okay.
So, so the next one we're going to go to a voice call. We're going to open up Patricia Launer's line. So, Patricia, if you're ready, we have your line open now, and you can ask your question.
She needs to enter her audio pin.
Okay, Patricia, I'm getting a notification here. You should be seeing on your screen an audio pin number, and you'll need to enter that in order to activate your audio system. So we'll come back to you in a moment. What we'll do now is we'll move over to Rebecca Woods. Rebecca also had a question. I see it in the panel as well here too. But Rebecca, your line's open if you want to ask your question.
Hi, Rebecca. Can you hear me?
Hi, I can hear you. Sorry, I was on mute on my side.
Oh, no problem.
Suzanne probably already knows our question because it's a heated debate here at Porter, but I'd like to maybe know what everyone is doing in terms of their proxies, and specifically the age 12 to 18 and allowing proxy users and how we protect them, especially when the CCD is out there on the portal, which includes everything. I guess that would be my question.
Yeah. Minors with patient portals, I've seen it done a broad range of ways. I have some pediatric practices who've decided not to offer the portal at all, and that they don't want to have to come into that scenario where they give the portal access to the legal representative or the parent, and then the 14-year-old girl gets on birth control and the patient has the parent has access to that information, or smoking status or whatever. So it's unfortunately a gray area, and the practice is going to need to make the decision what is going to be best for your patients and your patients' parents.
So for us, we fortunately or unfortunately have the same portal for hospital and practices. So I'd like to think we're doing something good for the community so that they only have one portal, but it seems to have its own problems as well, because we can't just, shut it off for the pediatric and and tell the hospital to exclude those patients. Does that make sense?
It does make sense. I don't, unfortunately, have a great answer for this scenario. Susanna, do you have anything to add for this pediatric scenario?
No, I've been actively working with Rebecca and the Porter Group and trying to decide how they're going to manage this.
Yeah, it's a big workflow debacle.
I think it's sort of workflow for everyone. I mean, we all have 12 to 18-year-olds, whether we all have one portal for
Right.
practices or hospitals.
Right.
But, with having the CCD out there on the portal, which really should have everything, but then allowing proxy for that 16-year-old parent, is that okay? And I've heard a lot of hospitals are actually just not allowing any type of proxy at all, and other hospitals are allowing age 12 to 18 to have a portal at all.
Right. So
it's so unfortunate.
It depends on what your patient portal has the capacity to do. Some,
Yeah.
You have the capacity to say, okay, I want all my parents to have access to patients age up to 12. And then when the patient turns 12, that the portal functionality is turned off, and then you could do it per patient scenario, and just decide on a blanket, that no patient between the ages of 12 and 18 will have patient portal. And then when they are an adult and they have, their own portal, then they choose to have that activated. There's different scenarios. It's going to be the capacity of what your technology can do.
Okay, it sounds like this one's going to need continued work from Suzanne and the team. So sounds like it's an ongoing discussion.
Yes, Dr. Kate McIntosh is our medical director here at VITL, and she's a pediatrician. She's been considering this challenge as well, and maybe we can put you in touch with Dr. McIntosh, and you can talk a little bit about how that's working for her and what things they may have implemented for workflow to consider that for you.
All right, great. I'd like to go back to Patricia Launer if I can, if Patricia's line's active now, Steve. Okay, so Patricia, I believe your line's open.
Hi, this is Patty. Can people hear me?
Yes, Patty.
Hi. So I'm just trying to wrap my brain around all of this, and as I've been talking to folks at VITL and looking on the web, it appears that Meaningful Use Stage 1, the CQMs for 2014, are very similar to, if not exactly the same, as the CQMs for Meaningful Use Stage 2. And I was just wondering if you can help clarify that for me.
Yeah, you got it, Patty. So CQMs did change for 2014 no matter what stage you're doing for meaningful use. And if you join us on Wednesday, the 2 Wednesdays from now,
19th.
the 19th, we will be doing a what stage 1 looks like now, starting in 2014 with the changes that have incurred. And one of them is that CQMs are changing for stage 1, and they are identical to what those who are doing stage 2 are doing.
Okay.
Great question.
Great.
Yes, thank you.
Okay, we also have a question out there from Jody Frey. So Jody, if your line should be open at this point, or just a second, we'll have your line open.
Sorry about that.
Great, can you hear me?
Hi, Jody.
Hi, thanks for taking my call. I have two questions.
Jody,
Hey, Jody.
could you turn your speaker down on your computer? We're getting a little feedback with echoing.
Oh, my speaker's all the way down on my computer. I'm on my phone.
That's better, actually. Whatever just happened is we're okay. We are getting a little feedback. Go ahead.
Better?
Yep.
So, can you clarify for me that we are in our stage 1, year 2. Is the 2014 certified technology required?
Yes, that's a great question. No matter what stage of meaningful use you're doing, the 2014 certification is needed for any attestation done in 2014, no matter the stage that you are attesting to.
Okay, great.
And no matter...
Question,
I'm sorry, go ahead.
my second question is around an e-health address. When we were down at training, our vendor, I'm sorry, I'm getting a horrible echo too, so I can hear myself.
Sorry about that.
Our Meditech vendor explained to us that in order for patients to view, download, and transmit, the patient has to enter the provider's e-health address, and this was not the provider's email address. Does VITL provide the e-health address?
No. I'm not familiar with what an e-health address is, but it sounds... Jody, I would be... This is Jen. And I would be happy to take this one offline with you since we work together on meaningful use for your organization. And I'd be happy to work with you offline on this with MedEnt and trying to get clarification on that one for you.
Okay, thanks.
Okay, I wanted to go back and add some clarity to one of the questions that was in the instant message earlier in the topic. Somebody asked about charging for patient portal, and we have been looking up the actual information on that particular measure, and it does indicate that there is some additional clarification. Well, I'll just read the statement to you. Additional clarification on the fee that a HIPAA-covered entity may impose on an individual for an electronic copy of the individual's health information will be addressed in upcoming rulemaking from the Department of Health and Human Services, Office of Civil Rights. So I think, we did a little in-house poll here, and we don't know of any situations where that's happening, but it sounds like there's more to come. And I'm getting some prompting here, so I'm going to wait. And so the same is true with paper records today. So that's very consistent with paper records. All right, so we have another question by voice. Balu Raman, how are you today? And your line should be open at this point.
Can you hear us?
Balu, are you out there? Okay, I think we're going to have to go on. So is there a question in the chat, Suzanne? If there's one you want to pick out and read as one to address by voice, you can do that for a minute, maybe.
So Nicole Bailey has one in the chat that is for the immunizations. I was under the impression that ECW and VITL had not created a link yet to be able to electronically download vaccines to the registry. Is this coming in the near future? So our immunization registry person here at VITL is working with all of the vendors and working to get them connected with the Vermont Department of Health. It's a long, laborious process, but that is one of the vendors that is being worked with at the current time.
Right, and then that registry is active. The link from VITL to the Vermont Department of Health is up and running, and we are actively connecting practices. As Suzanne said, there's information on the VITL website. If you search for immunizations, you should find the appropriate page. So I wanted to just go back and see if Balu had rejoined us here, if we can catch his question. Okay. All right, we're still not hearing you, so you'll just have to enter yours into the chat screen, and maybe we'll see it that way. And Jen, you've got one you're going to take?
Sure. We have a question from Tim Gould. Am I required to meet these requirements for meaningful use if I choose to opt out of receiving incentives? So yes, if you choose not to do meaningful use. You're not going to attest to meaningful use measures for stage 2 or 1 if that hasn't started by the EP. Then you just would not receive the incentives. However, keep in mind that at this point there is a disincentive for Medicare recipients, providers who receive Medicare accounts receivables. There's a 1% penalty beginning in 2015 for not being a meaningful user of an EHR and attesting to that. So hopefully that answers your question, and we're just going to take a look and see if there are any other web chat questions that we can share with the group. Okay, is there an immunization registry on a per practice basis, or are only certain EMRs able to do this? So the way that the immunization registry works is that you as an organization and your EHR will connect to the VHI, which will then push your immunizations to the Vermont Department of Health. And the way that they have been pushed out is by vendor, working on one vendor at a time. So for example, last February when the state went live with their immunization registry, the first vendor that pushed through, for example, was PCC, the local pediatric software. And so those practices were our first ones. And then as it was running, more and more have been pushing through, and every day it seems like we're getting emails from our internal saying that more and more immunization registries have gone live. So hopefully that answers your question.
Okay, so I'm just keeping one eye on the clock here, and I realize we're approaching 1 o'clock. So what I wanted to do is say that the VITL staff will stay on the line and will continue to answer questions, but I do want to be respectful of folks' time, and for those of you, if you do need to drop off at 1 o'clock, we certainly appreciate you joining today. We have 2 more sessions in this series of webinars, each of the next 2 Wednesdays at noon. And also within 24 hours, we will be posting a recording of this webinar. So if you do have to drop off, you'll be able to hear the rest of the questions if you want to just, move to the end of the recording and listen to that. So that'll be available to you, and then we'll also be able to provide a transcript of the written questions as well. So so again, thank you to those who do need to drop off, but the VITL staff will stay on. So I'll just ask Suzanne, why don't you just start at the top of the questions we haven't answered yet and just take them one at a time, and let's just probably faster to answer them by voice, and then we'll follow up.
All right, so there's a question from Ellen asking, did Jen just say that if I'm attesting right now for 2013 as stage 1, year 2, do you need to be sure that your program has 2014 certification?
Oh,
and the answer is no.
Right.
The 2014 certification applies to starting with this year, 2014, and it will apply to both stage 1 and stage 2 going forward. But for 2013, you needed to have the 2011 certification.
Right, so that's confusing because you still have a couple more weeks left of being able to enter your attestation data from last year for stage 1. So if you're still working on 2013 attestation timeframe and you're entering that before the end of this month, which is the deadline, then yes, your certification from last year when you were actually attesting, that's going to be your 2011 certification. Thanks.
So the next question is from Nicole Wilson regarding Measure 8, providing clinical summaries. We are able to provide these within a day, but very few patients ask for them or want them, so nothing is recorded for reporting purposes.
Okay, there's not an exclusion for, I'm not sure if I understand, so nothing is recorded, but there's not an exclusion for that. It's pretty clear that the clinical summaries need to be provided to greater than 50% of all patients. So I'm not sure if I'm answering your question exactly, but there's not an exclusion that talks about whether or not you report whether or not a patient. Right, so either you're printing out the summary on paper, you're pushing it to a portal, or the patient is declining. And if one of those three things happen, then it will count to achieve this measure. It will count in the numerator to achieve this measure. I hope that helps.
So the next question is from Heather Kendall. Does claiming menu objective exclusions count toward the number of menu objectives needed?
So this is a tricky one. So for stage 2, if you can achieve 3 menu objectives without choosing an exclusion, you need to attest to the 3 of the 6 that you can meet. If there are not 3 that you can achieve without choosing an exclusion, then you would need to attest to more than 3, and including the exclude. I hope that's it's one of these gray areas. So there could be the potential, and I haven't seen what it will look like on the CMS or the mapper sites of what stage 2 actual entry of the data into the attestation systems will look like. I would anticipate that, and this is an educated guess, but I would anticipate that if you're choosing exclusion after exclusion after exclusion on a menu objective, that they would require you to probably continue to attest all of the exclusions that are appropriate for every objective for the menu. And I hope that's helpful. Please, again, reach out to us, your eHealth specialists, if you end up having follow-up questions from these answers that we're giving today. We're just scrolling through to see if we have any other questions unanswered. Let's see. Course 17.
We got that one.
Oh, okay. Please include the rest of us on the patient portal topic. Scotty, thank you. Sure. So we will be doing a patient portal meaningful use webinar a week from today. We will focus on the patient portal, what we'll need, how to implement that into your workflow and how it can be best used, and all of the objectives that could be met through use of the patient portal. So I'm sure you will find great value in that next week as well. It looks like we've answered all of the questions on our web chat. So I'm going to turn over to Rob.
Okay. Well, once again, thank you. So thank you to our eHealth specialist team today. You've really given them some challenging questions, and that's what they're here for. So if you haven't taken advantage in your practice of having one of the eHealth specialists come and work with you in your practice, please take advantage of that. We will be posting replays of this webinar to our website, which is www.vital.net/mu-webinars. Again, thank you for joining today, and we will have the second in this series next Wednesday at noon. Thank you again.